So we are going to do a shoulder evaluation. So I'm going to be the therapist. Aisha, you're going to be the patient. So they're going to come in. The most important part is going to be the that interview part. So patient comes in. Go ahead and have a seat. And so with our form, right, we're going to go through there. We don't really need it just yet, but so tell me what brings you here.
I've been carrying my son a lot while I'm walking him to sleep at night, so sometimes it's like half an hour, 30 minutes, and like just holding him like this, he's getting heavier, so by the time I'm done, my shoulder's really achy by the end of the night. And just hurts to keep going to this position.
Got it. Allow the patient to give you details and sort of, because a lot of what you ask, you're gonna get so much out of that. And so follow-up questions, let them, oh yeah, so great, that's what brings you here. And tell me a little bit about, is it just carrying? Any other issues that, does it go up? When else?
Primarily just carrying him. It's like this one spot in my shoulder, like if I do this type of motion or if I'm holding him like this, and I primarily hold him on my left side, and my right hand is usually just supporting the rest of his body, but that's typically only where it aches. Almost every other motion is pretty pain-free. Like I can reach overhead, reach behind me, and all the other motions, it's just this that like is aggravating.
So just like Aisha went through, you have some patients that will just go on and tell you all kinds of stuff. I always just bring my laptop and I can keep my eye contact and look at their, acknowledging their issues and shoulder, whatever, and I'm just typing away. So it doesn't take away from your building of the relationship, okay? So then you'll go through full history. Where did it happen? How long has it been? Any issues with sleep, past history, review the intake sheet. And oftentimes, so you mentioned that when you're with your baby, right? Can you show me how you do it? So maybe you can bring maybe a bigger towel, but like, here's your baby. Like, show me how you hold your baby.
So he's more of a toddler now, so he's like in like 20,
so a little bit bigger,
25 pound range. So it's like I'm usually holding, his butt is resting on my forearm here, and I'm carrying most of his weight in my left hand.
So you're standing, right? Show me when you're standing.
Standing and walking. By the time I get tired, I start doing this. But I'm usually walking with him like this.
Got it. And so this is the time that as they're doing their thing, you're just sort of observing. The first thing I saw, you're like, yeah, his butt is here. I just saw that, right? And so looking for little things like that. And then at the same time, like, oh yeah, I can see you carry him a lot. And of course, all of this is going to hurt. Okay, let me just have you. And so after we go through a little bit of that history part and sharing, and like, when you reach, show me how you reach. Okay, so I do that functional assessment right around here.
Okay.
It helps the connection with the relationship. It helps acknowledgement, and that they know that you're connecting in what their problem is. Okay, so when you're here, let me see you face that way. Okay, and I use the mirror a lot. So even if you're in the little room, take that mirror out and have them see it, because now I'm going to have them just bring your arms all the way up, and you can do different movements. And now here, you're looking at scapular mobility. Good. Let me see you reach behind you to your opposite shoulder blade. Good. And then reach to the top. You're going to do both because you're observing. Look at what the scapula does at the same time. Good. Now you're going to reach across to that opposite shoulder, and you can see how much scapular elevation they do. So can you grab the side of your shoulder? Good. Can you now do this? Because if they are in pain, you're going to see, are they restricted to that lateral posterior shoulder because they may not be able to reach, or they're going to do this, right?
Yeah.
And if they can get there, how are they doing it? If they really reach and they're like, no problem. When you have them do this, that usually flares things up.
It's like awake. I can see more restricted on that side versus
this
side. This is like no problem.
So another place to look for, is there an anterior glenohumeral glide? Comparing to both sides. You did the scapular rhythm. Okay, great. So let me have you sit facing me. I then go into a cervical and thoracic exam right away. So screen, really. So let me see you look up and down. I did it opposite.
Sorry.
Look down and up, and then you turn to one side and the other side. Having that mirror already there. Now again, here it's great because it's that big mirror, but you can always put the other mirror on the side by the door in the little room, because from this position, I already see your sitting posture. I already see what that is scapular-wise. I see this, so it just gives me tons more information. Yeah. And then, so cervical, and then come all the way to the edge for me, and let me see, rotate to one side, and then the other side, and then you can see how much extra movement they do, and so you can either give them the foam roller to lock up their pelvis a little bit, or I'm going to keep them from cheating here, which when you get into that little room and it's tight, I actually sit in the chairs while they're sitting on the plinth and just sort of be able to see everything. Ready? Go ahead and turn to one side, and I can feel how much pushing, and I can really see what's going on there. Because that's going to tell me so much more, and it's a quick one. Okay, we've already seen movement. The other movement that I want to see is, let me see you bring your hands out. Good. Can you bring your hands here? Now, from the mirror there, I can also see how much external. Can you reach back there? Any symptoms? And then down, and you can see how much scapular control they have, because they're either doing this or not. Yeah. Right. So that's just another movement that I like to do. And scooch back a little bit. Oftentimes, depending on what's going on, if there's like, oh yeah, down into my shoulder, I could do a quick screen of the cervical stuff. And if there is some of that, I'll just quickly come back here and assess that first rib, assess soft tissue mobility. Give me a deep breath kind of thing. Okay. I can also assess extensibility. Keep this right here. And I'll do a little traction of that glenohumeral joint to see and compare it right at the joint line with my other hand. Wow, that one moves a little bit more than the other one. And at any time, let me know if anything bothers you, because I don't feel a thing. I'm just sort of going for things. So you're letting them know, and at the same time, like when they move or anything like that, asking permission, like, oh, is it okay if I lift the shirt? Is it okay? Like just because then, especially when someone's in a lot of pain, it gives them power over what they're in control of their painful places. Oftentimes you see the new person and they're like, eh. So, okay, so we got a whole bunch of stuff in there. So is it all right if we roll on your back? Yeah. Good. So just quickly, I'm going to bring this up a little bit. Let me see you reach all the way up. If you wanted, or you should, when you are in upright, come back, bring your arms up. When they were sitting and moving, you can take some range of motion for active standing up against the gravity. Oftentimes, I'll go to the non-involved and just sort of feel that scapular edge, inferior scapular edge here. How far does it go? Relax. The non-involved, I'm not really measuring anything. Sometimes when I'm keeping track, I do. And looking at scapular depression, relax here. Looking at that horizontal adduction, abduction, external, internal. Just sort of screening, right? How is that pec minor doing here? How's the tissue extensibility? And then the same thing here. We just sort of like, okay, let me see you bring the arm all the way up. If they're a little tentative, oh, that was the other side, but if they're, just for camera purposes, if they're a little tentative, you can see it. And if anything, you can just sort of guide them. I put my thumb right at the inferior scapular angle and get an idea of where they are. They go to whatever they want. And then just sort of like, oh, okay, and see it here. And just sort of, again, if I'm going to measure it, I'll just measure it from here. Let it relax. Oh, there you go. Good. We're measuring inferior. I go right into joint mobility, so let that relax. If they're in pain, I stay down here. Otherwise, I come right to this angle. If they have a good, fairly normal range of motion, I'll just test mobility here. I'm going to give you that because I want to make sure we get it here. So I'll test terminal glenohumeral mobility here, just kind of moving forward, backward. And then Keep that relaxed. Looking at the pec minor length. Oh, yeah, that's just a little shorter, right? Can you feel that stretch over there?
Oh, yeah, right at the end range.
Yeah. Just a little shorter, and we can just sort of see from there. From here, go ahead and you can sit up if you need to. From here, I go on their bellies.
Okay.
I don't know if you're up for that. I certainly wasn't up for that. But
Face in the hole.
yeah, nose in the hole. I will assess scapular mobility here. Even all the way down to their lumbar spine, I can just sort of assess everything. From experience, I found that I put a little roll underneath. That makes them more comfortable, especially if they're in pain and a little bit flared up, or if they're not, then just let them be. And I'm looking at here, spinal mobility. And then from here, I actually also go into scapular form. So this is just something that I can't come up with. Can you bring your shoulder blades all the way up? Yeah. So right here, I can see upper trap favoring her upper trap. So relax. Good. So oftentimes they don't really know what I want them to do because it's just difficult. They're not used to that. So I'm going to relax here. Bring that scapula into retraction and depression. Can you hold it here? Oh, that's pretty hard. So in your case, you're really holding it, but the serratus isn't really doing much, huh? You're like sticking, you're tilting. That's pretty hard. And then can you hold the arm right up there? When you brought the arm up, you added adduction that actually turned on your serratus, but now the lower trap's not really engaged. And then I go like this. Oh, that was a little, you can even see their lower body, how it shapes or changes or not, right? Are you okay with time?
Yeah.
Okay. So then I do the other side. So let me see you bring this one up. Oftentimes I've actually found this, that the non-dominant side does a better job. Hold it. Right? Is this your right hand?
Yeah.
Yeah, that's a significant difference, right? Yes. I could go into the official, middle trap. Can you bring this up? Hold this up here. Again, you're just sort of levator and upper trap dominant here. Yeah. Bringing it into external rotation can help people avoid impingement. If they have too much impingement, then just keep the elbow bent. Can you? Yeah, but see, you're doing shoulder extension or horizontal abduction. You're actually, or shoulder, no, you're doing extension. I forget. You're not actually doing scapular movement. You can't even, it's like, wait, what? Yeah. And like, no, stay at 90, just the shoulder blade. That's really difficult for you because you start right all the way up, right? Yeah. So relax. If they're able to, I get them into that thumb up position. I bring the scapula where I want it. Can you hold the arm here? And then this just like fires, and you can see what happens here. It's like, oh my God, because these aren't really firing. This is overworking. And so, is this okay here? So then we can go into an official lower trap. So you can set up the arm here. If it's a little tricky, I can always bring the headrest down because then that allows a little bit more freedom of movement here. Can you pick this arm up off the, no, not really. Not really without using this. So then I can also say, relax for a second. Okay, relax this here. I grab at the elbow and just sort of pull to get that scapular depression. No, don't help me yet. Yes, right there. Can you hold this here?
I don't know.
It's weak, right? Yeah. So lower trap. Okay. You are just so dominant on that upper trap and levator, right? Because then we have to teach you how to turn that on and not rely on that levator and upper trap. So yes, -3 for that lower trap over here. Obviously, then you go to the other side. If there is some soft tissue that I want to do, I just go right to it, especially through the upper trap and levator. That tends to just be super tight, and I expect, oh yes, I expect that to be right here, right? Yes. This is also a great place. Go ahead and put this here. If they are lacking that terminal mobility, I just come right up here. This is a nice place to work on inferior and anterior glenohumeral movement. So bring this here. This comes right to here. And then can see my butt. But that's basically your grip. Great. On your back, please. Slide all the way up. Not a little too far, Goldilocks here. Relax. And so from here, I go into supine again, because then I'm going to assess a little bit more of the, I forget I have a high-low table. I'm going to assess a little bit more of the cervical tightness and get a little bit of a neck stretch at the same time. So this is where...
There are 2 pins up here.
No, you're okay. I just sort of look in here. I sort of assess a little bit more length and sort of use this as a place where I can say, okay, we're just going to stretch. You can go right into treatment. I get a little pec minor stretch. I grab at the suboccipital region to get a little bit of a nodding, upper cervical flexion, so I can get a little bit more of the scalenes. You can then use your thumb to assess the length or lack of much length. And come right here. Good. You can then...
You want to even me out?
What's that?
You want to even me out?
I don't think you need to. Do you feel? We'll even her out. Look how much lower this goes. A little different, right? Yes, even people out.
Gracias.
Just because we love her. See, that a lot of that is scapular. Scalene. Your first rib actually moved well, but just all this, we just need to really release it on a different time, not today. And so touching everything that you would want to address in their treatment, meaning for their plan of care, this is the time to touch and be like, oh my gosh, yeah, this is a little tight. We definitely want to get into that, but not today. Then from here, I can do a little bit more soft tissue right at that pec minor area. That's where I would want to go with you. And maybe a little bit through here. This tends to be painful, so I don't go to it right away, especially not with an instrument on their first visit. Or down here, not very fun to go with that in the first visit because, it's a little bit painful. And we want them to leave feeling like, oh my God, that is so much better. Go ahead and sit up if you need to. But the other thing that I'll go into, do you want to see?
Yeah.
I like to see. The other thing that I like to get into when you're in prone is I'll go if there's scapular things to be addressed and I want to start up with prone scapular work. I just go right into that to teach them a little bit because then it's much easier to come back to instead of making them flip like pancakes. Okay, great. So let's see. So then once I've done that, a little bit of treatment, some of that, I'll bring them back to sitting. And then I'll start up with some of the home exercises. So in your case, I don't like to give more than 4, just sort of 2 is fine. Whatever it's, depending on what their life is like. And so in your case, I would have done the prone. Can you lift without using your arm? Because a lot of times people will do this. And that's a tricky one.
Yeah.
Also, you're going to, in your case, there's so much tightness through that scalenes that probably talking a little bit about that posture thing with the nodding, maybe doing a little bit of scapular retraction without, not so much the external rotation, but just really teaching that we want retraction to happen. I did not test your serratus anterior. That's probably a little bit weaker over there, but it could probably not be. It could just be lack of motor control. So keeping that in mind, that when I saw you in the functional assessment, it could be either or both. My guess for you, it's probably just motor control.
Okay.
You're probably super strong there, except for your lower trap. Why? Because you got little kids to hold on to. That's why.
What position do you like to test your serratus?
Supine.
Okay.
I will do a screen when I first had you sitting. I can do strength testing right there. When I just do a simple external, internal, a deduction, a abduction, and then I can also go right there into, and I'll do it on this side because since you We're already having an issue. Okay, you're going to hold your arm right there. I can see how the scapula is being when I just asked them to hold their arm. And then don't let me move. Don't let me move. Don't let me move. I can see. And then you can start to sort of go into like, okay, can you pinch the shoulder blades here? You can provide a little tactile feedback and then hold it here. And usually with that little bit of tactile feedback, they're like, oh my God, that's so much better. And that is just like a short, quick piece of big time education in how much their scapular activity and strength has an influence on their shoulder pain. If there's anything else that you have to clear, like spurlings, upper limb stuff, you can certainly do that at the beginning to rule things out. Other special tests when you are in supine or in prone. But other than that, after they've come up, and so I'm going to give you a scapular retraction, and you show them in PT wired. I also tend to mark on the software, on the EMR, like the color of where I saw the soft tissue stuff. If I see any incisions from old surgeries, I'll write it in there. Just because for me, visual, it's much easier. Instead of writing increased SDR, upper trap on the right, I just color it.
You use different colors, or you just leave the red?
There's only red.
Okay.
Yeah, unfortunately, there's only red for this one. If I didn't have that in their intake sheet, that's where I color.
Okay.
I used to have different colors. But I'll do it in the intake sheet if for whatever reason I don't have it. So at this point, I would say, since just really focusing on form, now you're a mom, time's precious. So how can we make small changes? That's where I'm going to say, okay, I'm going to give you the scapular stuff. You really need some lower trap strength. There's other strength that I would want to give for you, but lower trap, so we would do scapular retraction with the band. While watching that, I'd give you some scalene stretches, so really nod here, and not really pulling, just let gravity do it, which you could do while you're cooking dinner. You can do it while you're sitting on the toilet, even if the kids are all over you. And you can do that anywhere.
You're opportunistic with the exercises.
Yes. And that's probably all I would give you, because, so then we bring the trusty form, and then I say, okay, go ahead and put your shoes on, and while they're doing the shoes, while they're doing all that, then I take the time to write the top. Oh, big thing was, and I usually will ask it at the beginning, is, so tell me, what can I help you accomplish? First, I would say, oh, what brought you here? And then once they go, blah, 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 okay, so then what can I help you accomplish? Because us as therapists, we're not the ones doing it for them. We're going to help them. What's your goal? Goals have to be what?
Smart. You got to be, well, one, they have to be, yeah, that's, you can use the acronym, but
Yeah.
you got to make sure that they're meaningful and salient to the patient, that it's going to impact their, whatever it is that they want to be able to achieve that's functional.
Which is exactly why we're having the patients come up with them. We are not coming up with their goals. They're going to come up with them, so they always have to be functional. Acknowledge that they want, oh, I want to get rid of my pain. It's like, okay, another time to educate on pain. The pain is subjective, and we want to be objective about it. We want to be able to measure it, just like you said, the SMART goals. And so that's, you then write that on the goals, and you bring that back. Like, okay, that's what we're going to do. So then you write in the problem list, that's going to be basically your impairments. Oh, so you have pain because of this, okay, and this and this and this. So let's say in your case, we find there's shoulder impingement. Why? There's a decreased glenohumeral motor control and scapular motor control. There is the pain. Where's the pain coming from? Oh, it's a little bit of probably a tendinopathy or a subacromial impingement of some sort. You should have figured that out already. And if you didn't figure it out, then you can just say, well, it could be a little bit of this, it could be a little bit of that. Sometimes with the complexity of patients that we get, it's a whole bunch of different things. So just say that. Be like, well, it's a little bit of this, and I don't know, the chicken or the egg. It could be a little bit of both, and some days it's one and the other, or the other. And then lack of strength, that lower trap and scapula. Oh my gosh, they need a lot more strength. But they also need that postural endurance, right? And the motor control, I would say, is the biggest one for you, right? So then I will write all that before before I say anything. I'll write the problem list or impairments first and the diagnosis. So then, they're ready to get changed. So then I come back and I actually, okay, you came in because of your shoulder complaint. That's where you acknowledge their pain, right? But what is your goal? Oh, your goal is to be able, I didn't ask you before, but what's your goal?
To be able to carry my son at night for an hour or two and not have pain.
Yeah, you already created that nice goal for me. But that's when you can sort of modify it a little bit to make it work better for you as a therapist. And then you go through, okay, well, here's your problems. And then 1, 2, 3, you can add 4. But this is where you show them, and then you can create little arrows from 1 to 2. This is how this pain is caused by this lack of motor control, because this is lack of motor control because the glenohumeral joint that's stuck forward. Why is it stuck forward? Because you lack the motor control, and the lack of motor control then gives you more pain. And you can sort of, that's how they all sort of feed off of each other. And so my diagnosis, my physical therapy diagnosis is this: shoulder impingement, weakness, because there is no ICD-10 for scapular dyskinesia, which is ridiculous for all those other ones there. So weakness is usually always where I write scapular dyskinesia as.
Okay.
Tendinopathy, whatever it is you want to write in there. And then what's our plan? Number 1, we're going to do some manual therapy, which is kind of what we did a little bit. But the biggest and most important one is that neuromuscular reeducation. Then the home exercises, and then that's where we write down, okay, what's the third one? Okay, the third thing I really want you to do is really pay attention and notice that shoulder blade kind of pinching back. Not pinching back and up, right? Just sort of like, it's very subtle. It's very subtle. My ideal for you would be 2 times a week. Start with 2 times a week. There's really just a little bit of release, but the majority of it for you is going to be teaching that shoulder where it needs to be, right? And where it is in space. Teaching these muscles to stop working so much. And so I think that we can accomplish that in 2 times a week for maybe 2 weeks or so, maybe 3, like 2 times a week, because you want that repetition. Sometimes you may not think that they need 2 times a week, but if you only give them 1 times a week, then they don't have like, am I doing it right? Or maybe they do it right when they showed you, but then they go home and do it and they screw themselves up even more. And then it was your exercises that made it worse. Whatever. Ideally 60 minutes, but sometimes this is when I haven't addressed anything with pain, with financials yet, right? I just write my ideal and my recommendation is. And then home instructions, any changes to their activity, whether it's not, just notice, right? Or maybe you tell them like, okay, when you're carrying your baby, just before, the moment you pick them up, turn on those scapular muscles, right? Or maybe for now you lift on the other side because this is a little bit, we want to let it calm down. The exercises, you can just write down. You don't have to be descriptive. You can just say 1, 2, 3, 4 from whatever you put in the PT Wired app. And then that extra line, it's for whatever it is you want it or not. Okay. Now I'm going to sign it, and then I'm going to give it to you. You're going to sign this because this is a contract with you that you're going to reach that goal. And when you give them that, it's not just reaching the goal, is you're going to carry your baby for 1 hour at night, whatever it is you wrote. It doesn't have to be super long. Find joy in life again with movement, right? Ultimately, if the patient is like, oh, well, I don't know, and it's like, oh, well, everybody wants to be happy, right? So just sort of like, wouldn't you want to be happy with moving again? Like, because some people will just, everything's awful. So once you have that signed, then that's about it. Any questions?
Sounds good.
Yeah. You're going to screen some of the stuff, and you can cut them the TheraBand if they need it or whatever. And remember, you can, if you don't know something right away, you can always just do it the next time. Just go to basic impairments, because sometimes things will be like thoracic outlet syndrome coupled with rotator cuff tendinopathy, and this all happened right after they got their COVID shot. So there's just like pretty complex things that it just sort of acknowledge them, putting in the back, and then go from there.
Sounds good.
Good?
Yeah.
All right.
Yeah.
Questions, let me know.
Stay tuned.
Yay. Did we stop it? Did we stop it? I can't tell. I can't tell. Did we stop it? I don't know.